Good morning, everybody. This is updates on management of medullary thyroid cancer with Dr. Dadu from MD Anderson, and I'm going to turn the reins over to her, and we'll get started.
Yeah, wonderful. Thank you, Karen, and hello, everyone, wherever you may be. Here in Houston, it's 10:30, so good day. I'm Ramona Dadu. I'm an assistant professor in the Department of Endocrine Neoplasia and Hormonal Disorders at MD Anderson Cancer Center in Houston. And my area of expertise is in the management of all advanced thyroid cancers, including medullary thyroid cancer, and the use of systemic therapy. So today we're going to start with celebrating 10 years of big accomplishment in medullary thyroid cancer field. 10 years ago, this year, Vandetanib was approved for medullary thyroid cancer. But we have come a long way, and if you can see this list that in the past 10 years, there have been a lot of work and clinical trial being done, and we brought to the table many more systemic options for our patients with advanced thyroid cancers. But before we start about how we will manage with systemic therapy, I wanted to take just a brief moment to discuss the overall thought process about how we think when we decide to start somebody on systemic therapy. So as you know, the management for medullary thyroid cancer, the mainstay treatment remains surgery, followed by a very long period of observation. We then look into some localized treatment options such as surgery to any metastatic sites, external beam radiation, cryoablation, embolization, and so forth. For those who have bone metastases only, we often recommend zoledronic acid or Exgiva for bone metastases. And when all these treatment options have failed and patients have clinically significant disease or progressive disease or symptomatic disease that threaten vital structures, then we will, at the end of our pyramid, think about the kinase inhibitor therapy treatments. And when do we usually recommend starting kinase inhibitors? In general, we look for progression of disease within the last 12 to 24 months. We look for increasing size of lesions by at least 20% over the past prior year. We look for symptomatic and metastatic disease that cannot be treated with localized therapies. And we look for bulky disease compromising nearby structures, and those cannot be treated with localized therapies. In particular, for medullary thyroid cancer, other considerations are calcitonin and CA doubling time of less than 6 months and structural evidence of disease. So just rising tumor marker alone are not sufficient to make that consideration for systemic therapy. For some patients with severe or intractable diarrhea or Cushing syndrome and lack of efficacy of other medical treatments for these symptoms, then we may consider systemic therapy if the patients have clinical and structural disease. Some of the localized therapies we can apply in these settings are non-pharmacologic, such as surgery, external beam radiation or gamma knife to lesions to the lung, liver, or brain, thermal ablation to any soft tissue or liver disease, embolization, ethanol ablation, and finally, for the pharmacological treatments, we talk about bone metastasis treatment with either zoledronic acid or denosumab. And only after we kind of excluded all of this list, we go back to our kinase inhibitor treatment for progressive or symptomatic disease. And what are the reasons to reserve these treatments for only progressive and symptomatic patients? We know that the responses to our systemic therapies are incomplete. There are very few patients who have complete responses to this treatment, but cure has not yet been found. Eventually, all patients will progress or have an adverse event leading to discontinuation of this drug. And finally, these type of treatments come with a lot of cost from many aspects, but more importantly, from quality of life and financial aspects. So now let's talk about what are the FDA-approved drugs for thyroid cancer. For medullary thyroid cancer, we have two drugs approved, Vandetanib and Cabozantinib. For the other form of thyroid cancer, differentiated thyroid cancer, we have another two drugs, Sorafenib and Lenvatinib. And most recently, we have added a list of another 5 drugs that are tumor agnostic therapies. And what that means is that no matter what type of cancer one may have, if they have certain genetic abnormalities in their tumors, it could be thyroid, it could be lung cancer, it could be kidney cancer. But if there is a mutational analysis showing a RET positive cancer, one can use the newer RET inhibitors such as Selpercatinib or Pralsetinib. For patients with NTRK fusion positive cancers, we have 2 other drugs, Larotrectinib and Entrectinib. And for patients who have this mismatch repair in their tumor, MSI high or dMMR cancer, which is an immune-mediated mechanism, those could receive on-label immunotherapy such as pembrolizumab. But the question is, how did we get here? We went from no treatment for thyroid cancer 10 years ago to all of these very, very efficacious therapies. And the way we did it was with a lot of research, a lot of clinical trial, a lot of support from many institutions, but also thank you all for participating in the clinical trial and allowing for the field to move forward. But how did we find all these systemic therapies? And what we did many years ago, we just went back to the drawing board. We know that for any type of cancers, there are 10 hallmarks. And these are some of the mechanisms by which any type of cancer can develop and progress. And this is just a list of many factors that can lead to that tumor to growing. And in medullary thyroid cancer, in the pathophysiology of it, we found that the blood vessels tend to have a major component to development and progression. So angiogenesis is something that probably most of you have heard of, but in the face of cancer, stimulation of this lot of the blood vessels in the tumor can lead to more rapid growth and metastasis. We have also learned in medullary thyroid cancer through a lot of basic and translational research that has been done, that there are a lot of signaling pathways. So in the tumor cells, there are a lot of tyrosine kinase receptors that can activate on all of these pathways in the tumor cells, and that can sustain this tumor cell to continue to divide and does not allow the tumor cell to die. And so through all of these signaling pathways that are fed up through the tumor cells, one could have a continuous proliferation and continuous growth of the tumor, and then extension of the tumor in other sites. We have also learned that there are a lot of genetic mutation and alterations that someone with medullary thyroid cancer may have. And in particular, for the hereditary forms of medullary thyroid cancer, the RET mutation is the mainstay for that hereditary form. We have learned that in the sporadic medullary thyroid cancer, about 45% of patients may have a RET mutation, and we are talking about somatic RET mutations here. We are talking about the RET mutation that is present in the tumor of somebody with medullary thyroid cancer and is not the hereditary form. We have also learned that there are several RAS type of mutation in patients with medullary thyroid cancer, and that account for approximately 15%. We still don't know yet the mutational profile, and that's unknown in about 30% of our patients. We have looked at other aspects in the genetic part of the medullary thyroid cancer cells, and there are other things such as fusions in RET and fusions in ALK that could be present in those patients with medullary thyroid cancer. So look for the specific genetic mutation, and we could find something in about 70% of our patients. But how is that all of that research that took many years, finding mutations, finding signaling pathway, finding vessel formation within the tumor, all of that research has led to this list of drugs that now are available for the treatment of thyroid cancer in general, but many of them can be applied for medullary thyroid cancer as well. So we can see there is a huge list of drugs that one can apply in the treatment for medullary thyroid cancer. I'm going to briefly talk about Vandetanib in medullary thyroid cancer. This was the first systemic tyrosine kinase inhibitor that was approved for medullary thyroid cancer. And what Vandetanib does is blocks certain receptors and pathways in medullary thyroid cancer signaling pathways. It blocks the RET mutation, it blocks the EGFR receptor, and it blocks the vessel formation, the VEGFR. So it's an anti-angiogenic drug. Vandetanib was first studied in hereditary MTC at the 300 milligram dose, and it was shown at that time, back in 2010, that was quite efficacious in hereditary medullary thyroid cancer, with 20% of patients having partial response, 53% having stable disease. But you can see here on the plot, most of the patients had tumor shrinkage while taking Vandetanib. And about 73% of the patients have achieved disease control that lasted more than 24 weeks. But one of the first studies with this drug in medullary thyroid cancer. This was followed by the phase 3 ZETA trial in medullary thyroid cancer. And this is a trial that included patients with medullary thyroid cancer, but they didn't have to have progressive disease. About 2/3 of them, 230, received Vandetanib and 100 received placebo. And they were followed, and tumors were measured to see what the difference may be between the Vandetanib and the placebo arm. And what this study showed is that when you look at progression-free survival here in yellow, the patients who received Vandetanib had their tumor stabilized for a prolonged period of time, which was longer than the placebo arm. In the placebo arm, the progression-free survival was 19 months, and in the Vandetanib arm was not reached, but was predicted to be 30 months. The overall response rate with Vandetanib was 45%. So 45% of the patients benefited from this treatment with tumor shrinkage that lasted, predicted for about 30 months. So pretty good results right there with our first clinical trial. when they looked at overall survival with Vandetanib, you can see here that there was no difference in the overall survival between the placebo and the Vandetanib group. So based on these results, it seemed like people didn't live longer despite taking the Vandetanib. However, this clinical trial was not designed to look at overall survival. The primary endpoint for this study was to look at disease progression and progression-free survival. So we may not get a good sense of what the overall survival of these patients is. So Caprelsa or Vandetanib was approved for medullary thyroid cancer in April 2011, and it's available for the treatment of patients with medullary thyroid cancer. Next, I'm going to talk about the second approved drug for medullary thyroid cancer, Cabozantinib. Cabozantinib is another tyrosine kinase inhibitor, and what this drug does, it inhibits similar pathways like Vandetanib, but has a more potent angiogenesis inhibition. So it's a more potent anti-angiogenic drug, but it also inhibits c-Met and RET. So almost the similar pathways, but it seems like much stronger. This drug Cabozantinib was used in a phase 3 clinical trial for medullary thyroid cancer, and that was the EXAM trial. And what they've done in this trial was to randomize people to Cabozantinib or placebo. So 2/3 of the patients received Cabozantinib and 1/3 placebo. But the difference in this trial is that the patient had to have disease progression before coming into the trial within the prior 14 months. That was not required for the Vandetanib trial. And what is another important aspect of this trial is that the patients who received placebo were not allowed to cross over and receive Cabozantinib part of the trial. And what this phase 3 clinical trial showed was that Cabozantinib was much better than the placebo. The median progression-free survival was 11 months with Cabozantinib and 4 months with placebo. So what this means is that if somebody starts on treatment with Cabozantinib, in average, it is expected to work for as long as about 12 months, which is much better than placebo. In the Cabozantinib treated patient, the partial response, which is the shrinkage of the tumor by at least 30%, was noted in about 1/3 of the patients. There were no patients in the placebo arm that have achieved a partial response. That was 0. The median duration of response for those who responded to the treatment was about 14 months. The MTC trial of Cabozantinib looking at overall survival, again, the overall survival was not different, but you can see the patients who were started on Cabozantinib, the average survival time was about 26 months. And so what I want to convey here is that Cabozantinib or Cometriq was approved for the treatment of medullary thyroid cancer, and this was the first formulation to be approved. It is a capsule, and the only indication for the capsule, the Cometriq, is for medullary thyroid cancer. Since then, the company has changed the formulation to tablets, and there is a new formulation now of Cabozantinib called Cabometyx. And this formulation is a tablet form and is approved for kidney cancer, liver cancer, and now, as of a month ago, it's approved for differentiated thyroid cancer patient in the second-line setting. So it's extremely important when someone starts this Cabozantinib for medullary thyroid cancer to make sure that the right formulation is used, because these are not interchangeable. There was a study that was just published, not published, just presented at the ATA about 2 weeks ago. And they tried to treat medullary thyroid cancer patients with Cometriq and with Cabometyx to try to change all the formulation to tablets. And unfortunately, the trial couldn't show that the two are equally effective. So as of today, we will continue to use Cabometyx, which is the capsule form only for medullary thyroid cancer patients. And for everything else moving forward and all of our indications, the Cabozantinib tablets forms is to be used for different indications. I hope it's not going to be a lot of confusion from the prescribing doctors or from the pharmacy perspective. But for the two drugs that were approved for medullary thyroid cancer, the Vandetanib and Cabozantinib, they all went through very large phase 3 clinical trial before achieving approval for medullary thyroid cancer. There are a couple of considerations and differences in how those studies were done. But just few of them. The Vandetanib trial did not require progression prior to entry. Cabozantinib did. The crossover at progression, what that means is that the patient progressed on placebo. They were allowed to receive Vandetanib, but on this study, those who progressed on placebo were not allowed to receive Cabozantinib. The median progression-free survival is estimated to be 30 months with Vandetanib and 11 months with Cabozantinib. These cannot be compared head-to-head because the study population is way different for those who participated in these trials. And the overall response rate was 45 and 28% with Cabozantinib. There are problems that come with treatment with TKIs, and some of those problems are from the side effects that one may see with these drugs that we have approved for thyroid cancer. Some of the bigger issues are listed here. Diarrhea, it's present in at least 60% of our patients, and it's across the board with all of the TKIs. Hypertension in about 70% more commonly with Lenvatinib, but also with Cabozantinib and Vandetanib in about 1/3 of the patients. Hand-foot skin syndrome, more likely with sorafenib for differentiated thyroid cancer, but we do see with Cabozantinib in about 50% of the patients, and with Vandetanib in about 50% of the patients when they have rashes. Other considerations are weight loss and decreased appetite, especially with Cabozantinib and Lenvatinib. And with Vandetanib, a very important aspect is QT prolongation or EKG changes that need to be monitored very closely. So when Vandetanib was approved for medullary thyroid cancer, it came with a black box warning from the FDA for QTc prolongation. And so we now have to check EKG very frequently and make sure that QTc remains within norms. For Cabozantinib, black box warning was for perforation, fistula, or hemorrhage. And so for patients who start on Cabozantinib, we do look very carefully where the disease is and make sure there is no issues with the vital structures in the neck. We also are very careful about wound healing with these drugs, because while receiving such a potent inhibitor of blood vessels, the wound healing may be a big problem. And then another problem with these TKIs is that eventually the patients may develop progression. So this is a patient of Dr. who had large disease in the liver and was treated with Vandetanib and has responded on Vandetanib and remained on Vandetanib for about 18 months. When he progressed on Vandetanib, he was switched to Cabozantinib, and he benefited from Cabozantinib for another 16 months, but eventually progressed again, and he was started on everolimus, which he received for another 8 months, and then he progressed. So there is this ongoing resistance to several TKI that we use, and we are always working on finding what could be this resistant mechanism, why are patients progressing on these drugs. So after these two drugs approved, there was a few years of being quiet, but we saw that those patients still progress despite of these efficacious therapies. So we went back to the drawing board, starting to find what kind of mechanism of resistance one may achieve and how can we treat those who progress on these drugs. And we really went back to RET because RET is one of the most important oncogenic driver in medullary thyroid cancer, but also in other tumors. In medullary thyroid cancer, between hereditary and sporadic, we see more than 60% of RET mutations. So we went back and analyzed how can we achieve a more efficacious treatment for those patients, 60% of those patients who do have a RET mutation. So the past year or two or so have been quite active in the area of RET and RET inhibitors. I'm showing here one of the trials of one of the RET inhibitors, Selpercatinib, in medullary thyroid cancer. This was a trial that was published last year, included a cohort of patients who received prior Cabozantinib or Vandetanib, and after they progressed on those treatments, they went on to receive the Selpercatinib drug. And what you see here, that it was that the overall response rate was about 70%, but almost everybody had a response from this treatment with tumor shrinkage. And remember, this was after failing Cabozantinib and Vandetanib. In those patients who did not receive prior treatment, so these are patients who have a RET mutations, but they have not been on Cabozantinib or Vandetanib, and they were started on the RET inhibitor as their first line of treatment. In these patients, you see that the overall response rate was almost 75%, but pretty much everybody had tumor shrinkage receiving these RET inhibitor drugs. It was very encouraging and now approved for medullary thyroid cancer. Another clinical trial with another selective RET inhibitor, Pralsetinib, was also published this year in Lancet Endocrinology, and they had a similar cohort of patients who received prior Cabozantinib and Vandetanib, and another cohort which was treatment-naive patients. Their first line of treatment was Pralsetinib, and you can see here, regardless if one received the drug or not, the overall response rate was again very high in 70% of the patients, but almost everybody benefited with tumor shrinkage. The median progression-free survival and overall survival of these drugs are not yet reached. Patients continue to benefit from these treatments, but we don't know yet for how long. There are many patients who are on this drug for years. And based on these two trials, and you can see here now, we have two other drugs that we added to our list of treatment options for our medullary thyroid cancer patients. Selpercatinib was approved in May 2020, and Pralsetinib was approved in December of 2020. And the approval comes for RET-Mutant medullary thyroid cancer, but for other patients who have RET fusions and do not have medullary thyroid cancer. Selpercatinib name is Retevmo, and then the Pralsetinib is also a tablet, and the commercial name is Gavreto. So much more has been done and added to our list, and we are very pleased with these achievements. What are the side effects with Selpercatinib and Pralsetinib? In general, they are mostly low grade. There are no concerning issues so far with these drugs. We still have a lot to learn. Hypertension of any grade was present in about 30% of the patients treated with Selpercatinib. Increased liver abnormalities in about 28 and 26% of the patients, but as I said, usually low grade. Hypertension can be seen with Pralsetinib again, but about 11% of the patients, and white count abnormalities can also be seen in about 10% of the patients. So in general, the percentages are much lower than we are used to see with other TKIs, and also the grading and the severity of these side effects tends to be much low grade. When one compared the side effects of the 4 drugs approved for medullary thyroid cancer, Cabozantinib, Vandetanib, Pralsetinib, and Selpercatinib, you see that there is various side effects. They are different, more low grade, and usually better tolerated with the RET inhibitors. And now that we have these 4 drugs approved, it's really important to know the mutation in patients who have medullary thyroid cancer. So if one is to be considered for systemic therapy, if it's time to start on a systemic therapy, know your mutation is extremely important in 2021 to know about that, because the treatment algorithm may change right now. And how can this be changed? I think we came to the conclusion that mutational profile or mutation now drives how we treat and how we decide which drug to use first. And in general, in patients who are ready and have progressive medullary thyroid cancer, we look for RET mutations because we have now 2 excellent drugs that can be used, and we start RET inhibitor treatments in those patients. For patients who have a RAS mutation, we can choose between Cabozantinib and Vandetanib, and it takes a lot of thought process which drugs to use first. And for those who don't have a RET and don't have a RAS, Cabozantinib and Vandetanib still remain a really good option with, again, a lot of thought to be put into which drug to start first. Another point I want to make here is that if there is no tumor to look for those mutations, one may consider using liquid biopsy, which is a blood test that can be used for testing of RET. And no matter where we are in the treatment option, I think in the treatment algorithm that a RET needs to be looked for in the tissue or in the blood. There are, as I said, a lot of patient-central algorithms that we recommend one uses when selecting for this tyrosine kinase inhibitor. When it comes to selecting between Cabozantinib and Vandetanib, there are a lot of things we looked at: QT prolongation, history of gastric ulcer disease, diverticulitis, hemorrhage, history of medications that prolong QT, history of low calcium, low potassium, low magnesium, history of tumor invading into the trachea, esophagus, or blood vessels. Patient medications, take a look very carefully at what is the medication list and what kind of enzyme can be activated with the drugs. Look at how rapid is disease progressing. Look at the body mass index, how thin or obese that patient in front of you may be, and is the patient willing to protect or comply with sun exposure. There's a lot of things that needs to be taken into consideration by the treating physician to decide between which drug may be more appropriate to start in the first line setting. And that's when decided between Cabozantinib and Vandetanib. There is a lot of monitoring that one needs to do while being on these chemo drugs, but in general, we do a very comprehensive evaluation before starting on these medications. We do a physical exam, a blood or urine analysis, EKGs. We do staging studies to look for the disease status. We have our patients meet with our clinical pharmacist or provide educational handouts and talk a lot about the expected side effects and how to treat those. Then we have the patient start on the drug. We have the monitoring for these side effects that could potentially occur. We have office visit quite frequently. Initially, it's much more frequent, typically every 2 to 4 weeks for the first 3 months. If everything looks good, we can space the visits out to every 3 months. But extremely important to have images, blood work, EKGs, urine analysis, and adverse event checkouts every 3 months while during receiving these chemotherapy drugs. I'm not going to finish my talk without just commenting on immunotherapy. There is a lot of work there. There is a lot of activity in the immunotherapy world, especially with the Nobel Prize that Dr. Jim Allison received here. What are the types of immunotherapies? There could be a lot of ways one can make the immune system being more powerful and allowing your own immune system to then attack the cancer. And throughout the history of immunotherapy for many, many years ago, there has been many ways that this immunotherapy have been delivered. We know about vaccines, about the new checkpoint inhibitors, about the CAR T-cell therapies, and various other ways of how we can trick our own immune system to be more powerful and attack the cancer. We have done some work here at MD Anderson looking at various aspects of immune microenvironment in thyroid cancer. So what we did, we looked at the tumors from medullary, differentiated, and anaplastic thyroid cancer. And what we found that medullary thyroid cancer has the least immune infiltrate compared to the other thyroid type of cancers. So we call medullary thyroid cancer a cold environment where there is not a lot of immune activity going on inside the tumor cells. And how we looked at this is through a very thorough, comprehensive evaluation, looking at all kind of immune cells, T cells, B cells, all immune cells that could be seen in the immune environment of tumors. And what we found in general, that immune cells in medullary thyroid cancers are very, very sparse. It's not like all are cold, but the majority are cold. We have then done this trial here at MD Anderson using immune check inhibitor, Ipilimumab, which is a CTLA-4 antibody, and combined it with radiation. This was a trial for all types of thyroid cancers, but we included MTC patients as well. And these are the green patients here on this study. They did not benefit from this type of treatment. There was another clinical trial done by Dr. Lord, and that was combining Ipilimumab now with another immune checkpoint inhibitor, nivolumab, so going for 2 immune therapy at once. And again, this trial was done for all type of thyroid cancer, but medullary, 7 patients were included in that trial. And you can see the benefit was not as great and one would expect. Only 2 patients had stable disease, but 4 progressed out of the 7. And the median time of how long they benefited from that treatment was quite short, about 2.6 months. So we conclude that in general, these immune checkpoint inhibitors do not work for medullary thyroid cancer. There is much work to be done, combining them with various other strategies, but in general, we do not recommend that patients receive immune checkpoint inhibitor as a single agent in medullary thyroid cancer. Just going to spend 2 minutes before we open it up to questions about where are we going from here. Don't forget clinicaltrials.gov. It's a very good way to find what's active and what's recruiting in the world for different type of medullary thyroid cancer. I'm highlighting here 3 clinical trials I think that are now recruiting and are interesting. One is a CAR T-cell therapy in medullary thyroid cancer. It's engineered T cells to recognize this receptor, which was found to be present only in calcitonin-producing cell in medullary thyroid cancer. And this is at University of Pennsylvania. There is a clinical trial with RET inhibitor prior to surgery. So for example, if somebody has a medullary thyroid cancer with a RET mutation and has not yet had surgery for the neck, one may consider receiving the RET inhibitor first, try to shrink the tumor in the neck and possible achieving a better outcome from the surgery. And that trial is done here at MD Anderson with the PI Dr. Zafiri. I think this will be open up to other sites soon. And then this is the largest trial that is now recruiting patients, trying to answer the question of which drug should we use first for those patients who have a RET mutation. So this is a phase 3 trial. It's going to be open at everywhere across the world in more than 150 sites. And what this trial is going to do is to divide the patients in either receiving a RET inhibitor, Selpercatinib, versus receiving the standard of care Cabozantinib or Vandetanib, and finding which drug would be best to use first. For those patients who receive Cabozantinib or Vandetanib first, if they do progress on these drugs, they are allowed to receive Selpercatinib as their second line of treatment. So this is enrolling and would be a good study to answer those questions. And I think that's all I had. Thank you all so much for being here. It's not as fun without seeing you all. I wish we can soon meet in person, but thank you so much for being here, and I'm ready to take any questions. After breaking through Vandi, Cabo, and Loxo 292 over a period of 14 years, what's my next step? It's a very good question right there. So 14 years of that's an amazing result right there. I think the most important part after progressing through these drugs is to really look for the resistant mechanisms. So if not done yet, I would recommend a biopsy at the time of progression. Either from the progressive lesion would be the most appropriate. There are some now known mechanisms by which patient may progress through the RET inhibitor, through like gatekeeper mutation development or RAS mutations and so forth. So extremely important at the time of progression to obtain a biopsy of the tumor that's progressing, finding the resistant mechanism, and try to guide more tailored treatment based on that. So I hope you can find some answers and get into more treatments. Which of these drugs will be best for a patient with HRAS mutation? That's a very, again, a very interesting question. The RAS mutations tend to be more difficult to target. There is right now no targetable mutation for HRAS itself. Cabozantinib and Vandetanib still have a very good efficacy for those mutations. Again, without knowing the case per se, it's hard to say which drug, but in general, choosing between Cabozantinib and Vandetanib will be my first choice. After, again, doing that thorough evaluation for many factors, we'll look at which drug would be better suited for first line. I can get my head around increased progression-free survival, but no difference in overall survival. Can you explain how that happens? It seems counterintuitive. Yeah, so all of these clinical trials are designed to look at progression-free survival. So it's extremely hard to measure overall survival. It doesn't mean there is no benefit, but you can imagine that if somebody starts in a clinical trial with drug A versus placebo, you will see that when the patient progresses on placebo, definitely that patient will go ahead and receive a treatment. So although they started with a placebo versus active treatment, everybody at the end of the day ends up on an active treatment. So I don't think we will ever be able to answer the overall survival question. And again, we don't know because everybody eventually goes on those drugs. The only way we can answer a survival question by statistics would be not ethical, would be just treating a group of patients and not treating one at all. And that will never be able to be achieved, and it's not ethical to do. And it doesn't mean we have to report survival curves, but that doesn't mean there is no benefit. It's just there is no way we can know and do a good study for it. How likely is it that the medullary treatment guidelines will be one day be changed to suggest RET inhibitor before the initial thyroidectomy for those patients that are RET positive? It depends what kind of distant disease that patient may have. So if the patient only has presented with their initial diagnosis of medullary thyroid cancer or with disease in the neck, the treatment will remain, the mainstay or treatment for those patients will remain surgery. Now, is the patient having a huge disease burden in the neck where there is a lot of invasion into the trachea, into the esophagus, the surgery would probably require a laryngectomy or a tracheostomy? That's a different question. I think that if we are able to show that by starting a RET inhibitor and by shrinking the tumor away from the trachea, away from the esophagus, we are able to achieve a surgery that's not as morbid and does no longer require laryngectomy or tracheostomy, then that could be a really good option. In terms of changing guidelines, that will take quite a bit of a time. It's not as easy to change the guidelines that quickly, but again, we are doing a clinical trial right now to answer that particular question, and we are hoping that at least it can be taken into account. There are a lot of centers of excellence right now that would consider such an approach when deemed appropriate. So I think we will see that more and more for the RET mutation positive patients. How are white and red blood cells affected by these targeted therapies? Is this a concern if either red or white become elevated one on the therapy? So the white and red count are affected by decreasing the counts. Any increase in the counts could be related to something else. So if I would see somebody with high white count, I would want to rule out infection or other things going on. But in general, the RET inhibitor affect the counts by dropping them, not increasing them. With the fast-moving changes in therapy, what can a patient do to make sure their tumor is retained or preserved for future testing? That's a very great question. For many patients to have their testing done, the quality of the tumor for testing is the one that's the freshest. So the longest it's been kept, the less likely, the more likely that there will be some changes in the DNA and RNA. For particular, the medullary thyroid cancer, with just checking for the mutations and not the fusion, we can use pretty old specimens. So they still could be very good, even many years down the road. For those who may require systemic therapy and there is no tumor available, or the tumor does not yield a very good result, there is the option for those patients to biopsy at that time of starting systemic therapy, or doing the liquid biopsy, the blood test, to look for the RET mutation or other mutations. So there is nothing from the patient perspective that I think needs to be done. The tumor is usually preserved pretty well by the pathologist. But as the older it gets, it could be that the least the least that the mutation could be found. So it's just doing a biopsy or a liquid biopsy. How effective is liquid biopsy? Is it effective if no mets are visible on scans? Liquid biopsy was for RET mutation, was developed by Dr. Coate here at MD Anderson, and probably a lot of you have met and know about him. I actually, in his office, I got to get his office after he retired. So I'm very pleased that I'm following in his steps here. But there is a RET mutation liquid biopsy that was developed here at MD Anderson, and we can use it quite a bit. It's not as sensitive if there is no tumor on scans. So all of those that were tested had to have disease somewhere in the lung, bone, liver. So without disease visible on scans, it's unlikely that, I don't know if we ever tested, to be honest, but I'm not expecting to seeing that circulating in the blood if we don't see it on scans.
Dr. Dadu, I would like to hop over to the chat for a couple of questions, because we only have a minute or two left. And Harlan asks, and I'm not sure if I've got this right, why are renal clear cell, maybe that's cancer cell patients, on such a low dose of Cabo compared to MTC patients? Generally, they are on Optivo and around 40 milligrams of Cabo. I thought that Cabo opens channels to make Optivo more effective. Has there been studies involving, I don't know if you see that question.
Yeah, so as I said in my talk, be very mindful of the Cabozantinib formulations. It's extremely important because the Cabozantinib was for medullary thyroid cancer. It's different formulation that is used for anything else. So the Cabozantinib or Cometrix for medullary thyroid cancer is a capsule and has different dosage. What is used for renal cell carcinoma and for differentiated thyroid cancer right now, it's a different form, it's a tablet, and it goes for maximum of 60 milligrams. So it's a tablet, it's called Cabometyx, and it's 20, 40, 60 milligram tablet. The highest dose is 60 milligram. For medullary, it's 140 and it's capsule. So it's not comparable doses by doses. So we cannot say that they use lower doses of Cabo for RCC. In general, they tried to look at 140 milligram capsule of Cabozantinib for MTC and 60 milligram capsule that they use for RCC. They did a clinical trial and they didn't meet statistical significance. So they cannot say it's equal yet. So the FDA will not allow us to use the tablets for MTC. But to answer your question, so it's not the same formulation. The dose is not different because it's not a direct comparison, but it's a great way of trying to trick our own immune system by using this Cabozantinib first for a while and then starting to seeing a shift in the immune environment within the medullary thyroid cells and then follow that with immunotherapy. And I have tried to do that for 5 years. I am no longer pursuing that right now, but we were able, what we did was retrieve some tissues for patients who were treated with tyrosine kinase inhibitors and looked at the immune environment after they received the tyrosine kinase inhibitors. And it appeared that in those patients, the immune environment tends to be a little hotter. So it may make a good sense that for the immunotherapy future, we could use ways to trick the immune system to get it into the medullary thyroid cancer cells. We can use Cabozantinib, maybe RET inhibitors, I don't know, something first, trick the immune system, and then use these immunotherapy drugs following that. So those are
Dr.
all good
Dadu,
questions.
Dr. Dadu, we have more questions, but we are out of time. But I want to
Okay.
thank you very much for your time and to spend it with us. It was good to see you again.